Well, good afternoon, everyone. I want to welcome all of our panelists and all of our attendees to our next installment of our Advocacy Grand Rounds series. My name is Justin Lowenthal. I'm a board member and the Director of Partnerships and Strategy with Doctors for America and an MD PhD candidate in Baltimore. And I will be your moderator for today's Advocacy Grand Rounds, both now and this evening. The purpose of this series, for those who are new to it, is to provide the more than 20,000 physicians, medical trainees, and other health professionals in the DFA network, in the DFA family, with monthly training opportunities and courses to help support and supplement their advocacy efforts. These are modeled after the clinical grand rounds that many of us are familiar with, but with a health advocacy and activism spin. Our hope is that it will also provide all of us, doctors, medical students, and allies, with an opportunity to connect with each other and do health advocacy work together that's of interest to us. I encourage all of you who are on the call to share the 8 p.m. installment of this event, as well as future DFA events, with any colleagues that you work with, any trainees, friends, or like-minded organizations that you work with. We would also love to hear your suggestions for topics, for speakers, for how to improve this series or any of our other programming. We do these events at both 1 p.m. and 8 p.m. so we can offer options to members on all coasts and in all clinical practice environments, and hopefully maximize the number of people who can attend. While the content will be the same for each session, the Q&A conversation may be slightly different, although always fun and robust. And we will be live streaming to Facebook Live, as well as making a recording available and materials from the speakers. There are a few ground rules that we typically like to reiterate. One is that there is no such thing as a stupid question, so please ask or comment any and all questions you might have, regardless of how extensive or trivial in the Q&A. In terms of the questions, please use that Q&A feature. We'll address the questions as much as we possibly can in the second half of the session, and look out for comments in the chat. DFA staff will be sharing helpful links and providing housekeeping details there as well. And the last thing is that please be mindful in your questions or commentary that all of us are at different stages of experience in doing health advocacy. This is a first step for some, and for others, a continuing education opportunity. And we welcome each of you from wherever you're at in your journey in advocacy to encourage patience and good intentions from everyone. I'm really excited about today's topic. It's about building robust partnerships with local organizations, and it's never been more relevant for us to discuss this in the midst of the COVID pandemic and trying to get every pocket of the United States possible vaccinated. We're incredibly grateful to our two panelists today, Dr. Joia Mukherjee and Dr. Isabel Cruz. And our objectives today are really to focus on those local organizations and local groups that we can build partnerships with in our advocacy. We sometimes need to build that partnership with like-minded organizations who can help support our advocacy efforts, and sometimes we want to partner with them in order to support their work. We hopefully will understand components that make this strong and successful, and these partnerships trusting and sustainable over time. And we really want to dissect how organizations can use successful partnerships to share the work of advocacy and the effort and the volunteer capacity that we all have, especially in an environment where there's so much to do and limited funding and resources to do it. So I'm really excited to introduce our first speaker today, Dr. Joia Mukherjee. Dr. Mukherjee is a physician, educator, and activist. She's trained in infectious disease, internal medicine, pediatrics, and public health. Since 2000, Dr. Mukherjee has served as the Chief Medical Officer of Partners in Health, a well-known international medical organization with programs across the world, in the United States, in Haiti, Rwanda, Sierra Leone, and many other countries, as well as in the Navajo Nation, and now in cities across the US as a response to the COVID pandemic. Dr. Mukherjee is also an associate professor in the Division of Global Health Equity at the Brigham and Women's Hospital, and she runs the Master's in Global Health Delivery at Harvard Medical School. She's the author of a recent textbook, Introduction to Global Health Delivery, Practice, Equity, and Human Rights. And her scholarship focuses on health delivery, universal health coverage, and human rights across the world. And we have no better expert to talk about how to partner with organizations on the ground than Joia, who is also a mother and a singer in her free time. So with that, I'm going to turn it over to Dr. Mukherjee for her presentation.
Great. Thank you all so much. It's really a pleasure to be here with the Doctors of America. I'm actually in Haiti right now. I just was a little delayed because I was rounding on the pediatric ward here and saw our Haitian residents do pediatric resuscitation of a newborn, diagnosis of patent ductus arteriosus by ultrasound, putting homemade CPAP on the child, resuscitating the child, all in 10 minutes. I've never seen anything like it. At Children's Hospital in Boston, that would take us several hours. So it was just really impressive, what they're able to do here. And I'm just so proud of the residencies for Haitian doctors that we've built together with the Haitian government. So wanted to tell that great success story amid many difficulties. So, and I'm just really delighted to be here and hear what Isabel has to say and, really admire the work that Doctors for America has been doing since the Obama campaigns early on. I was asked by the team to talk a little bit about advocacy and the kind of advocacy that I've done, that Partners in Health has done. And so I'm going to share my screen. And let's see, there it is. We're all very used to Zoom these days, huh? Okay, screen share is there. Hoping you're seeing that. Slideshow. Okay, so I want to talk a little bit, and I will try to keep, I'm going to take my watch off so I can look at it. I'm going to try to keep to 10 minutes so we can hear from Isabel and have some time to discuss. I want to talk a bit about sort of the legacy of Verkau, who, as you know, is considered the father of modern medicine and really was a physician activist himself and was the father of social medicine, what I consider myself a practitioner of. And he, had the famous phrase, physicians are the natural lawyers for the poor. And if you're a lawyer for the poor, what are you doing? Well, I would say you're collecting evidence, which is what we do with our physical exam, with our history, with our social history. And we're then advocating for justice. And so we use evidence to inform our advocacy and fight for justice for individual patients. And many of you do that all the time when you're making sure people get a bed or get the treatment they need. You're fighting with insurance companies or, perhaps on a larger scale when you're fighting for a single payer or on, or on a global scale. And so I'm going to talk about sort of organizing principles and things that, there we go. Oops. Dr. Julius Richmond, who was a Surgeon General in the United States, who was a member of our department, Department of Global Health and Social Medicine, he actually wrote about the way we fight for policy change as physicians. And he took on big tobacco. That was his most famous fight, but he also was one of the founders of Head Start. And he talked about having a social strategy. What is the organization of and methods of communication? Who's in the organization? I'm going to talk more about that. The second piece of this, how we fight to change policy, to have social change, is really having a knowledge base. What are the sets of things that we can, as physicians, bring to the table, the data, the information, because sometimes data changes the world, but often it needs to be paired with a social strategy. And then the third is really the political will. Who are our allies inside, the policymakers, the people who are going to get budget appropriations. And so in these three areas, which are really interrelated and are going to speak to one another, that's how he said we actualize policy change and social change. And that has been my experience as a physician activist for the last almost 25 years. And then the second person I'm going to talk about briefly is Marshall Gans. Marshall Gans is a professor at the Kennedy School, but most importantly, he is a well-known organizer. He left Harvard College to work with the Student Nonviolent Coordinating Committee in the South during Freedom Summer in Mississippi. And after that, he helped organize the United Farm Workers Association of America with Cesar Chavez. And he has a very clear set of things that he talks about. And again, in my experience, these are quite valid. The first is creating a shared story. So as we seek to organize for change, it is important to have a story that tethers us to the work. And why is that important? Well, I think we all know that there is an entity called death by PowerPoint, and many of us have committed that. And the idea of organizing is to engage people in our lives. And so I often tell my own personal story of how I got involved in, health justice and advocacy, stories of my own life. My father was a tuberculosis and famine survivor from India, or I'll tell stories of, seeing many people die with HIV. There are many stories. It doesn't have to be one, but some way that you yourself are tethered to this movement, whatever movement that might be. The second thing is the story of us. What brings us together? In this case, we're health professionals, right? So I'm going to talk, our story of us is really about why we care as health professionals in Doctors for America about this topic. And then now, what is the opportunity we face, right? Because social change and advocacy always hinges on a moment in time. And that moment in time may take years, like it did for the abolition of the transatlantic slave trade or the civil rights movement. But there's a moment to be active. There are a series of moments, and there are a series of changes. And so trying to get people to understand what is the issue we face now. Is it a bill that's going before Congress? Is it the global health, the World Health Assembly? Is it the United Nations meeting? What are the things, what's the now that we're working on? Because that is a way to keep people motivated. Then we create, the second thing Gans talks about is creating this shared commitment. So what's our intentionality? So there are friends I've met from the movement who I can call up, who are really activists. Asia Russell comes to mind, a great HIV activist, or Greg Gonzalez, and I can call them up and say, what action are you planning, right? Because they know how to turn people out. But I know the details on the medical side. So how can I help? Right? And then creating a structure around that and a shared strategies, goal, mapping, tactics. That shared strategy is the meat of the work, but the first two are very important. And then the last is, what are we asking for? And I think when you hear the criticism of something like Occupy, and I'm not a critic of Occupy, by the way, but what people will criticize is there wasn't a clear enough ask. There wasn't a clear enough action. So I think that, now if you say that the action was to enlighten people about the 99%, I think they did a great job of that, and we're seeing the legacy of that still. So I'll tell you my own story as the clinical chief medical officer of Partners in Health really has been informed by walking with my teams, by going in the field and literally visiting patients in their home and seeing that the social forces are really what cause massive inequality. It's not the biomedical version. And so much of my life has been seeing children die of malnutrition in a world that has a lot of food, and really trying to understand why that is. And so for the last 22 years as Chief Medical Officer of Partners in Health, whenever I'm in the field, I'm doing home visits, I'm seeing patients on the wards, I'm talking to my colleagues about their needs. And so that has really informed my work. So now I'm going to talk specifically about COVID, us now, right? Which is, around the world, there was this notion of pandemic preparedness. And in fact, just before COVID hit the world in late 2019, a report was put out by Johns Hopkins, the Nuclear Threat Institute, and the Economist Intelligence Unit, looking at a metric for pandemic preparedness. And this metric put the United States right at the top. And I think all of us who are here today for Doctors for America understand that we don't have the world's best health system. So there are errors in this that we can attest to as frontline providers who are seeing the gaps and who maybe could have predicted that the US would not have done so well. I'm not sure I would have thought we were the worst, but I would have not put us at the top. And many of you wouldn't have either, because we have seen our public health infrastructure gutted, because we have seen that the social determinants of health, things like housing, things like access to care in Black and brown neighborhoods, our immigration policies, were really putting millions of Americans at risk for ill health and really at risk in this pandemic. So again, that's part of why we're together today talking about that, right? So, obviously the United States didn't do well. Here's our cumulative case rate. So what is the role now of evidence, right? Its evidence can be a bunch of different things. It can be personal stories. And I think indeed, many of you who've been on the front lines of provision of care, you were powerful voices to talk about the need for vaccination, the need for higher access to care, et cetera. There's also data. And there have been, a variety of very excellent papers about race and COVID and accessibility of treatment. And so there's a huge knowledge base that we can contribute to a movement for change around, one, COVID, but two, around the US health system. So, in my work, as I said, walking with people, what I did understand and what we as partners in health could bring to this sort of work in COVID is understanding that by getting deep into the community is where you deal with these social determinants of health. It's impossible to sit in a hospital and really advocate and understand and know. And so walking with community health workers, these are two of our community health workers in Peru who early on, they have tons of trust. They're from the communities and they could be diagnosing COVID in homes, delivering food in homes. They knew exactly what people needed. We've seen success around leadership, and so we helped to publish that and show the government of Peru that. Similarly, in Rwanda, we know what leadership in a pandemic looks like. We were able to share that with other governments in Africa and even with the United States, although they didn't care to listen at first, but certainly lessons learned from Rwanda were something that we could publish, put out together with our Rwandan colleagues and share with other governments. And then lastly, the place I am right now in Haiti, because we had fought for higher levels of care, we were one of the only places in Haiti that had an ICU capable of providing care for COVID patients. The hospital Mibale, where I am right now, we have oxygen, we have ventilators, we had PPE for health workers, et cetera. And so, but we also know, because we have community health workers, we know that need for the social determinants of health. So all of that was the story that me as person from Partners in Health, we as Partners in Health could bring to this problem of COVID in the United States. So we were asked, based on our work around the world in health equity, to support first the state of Massachusetts and then later some of the cities and states, as Justin has told you. So I'm going to just briefly talk about what we did. We said we understood that that to do prevention, to try to prevent the spread of COVID, either before vaccine, just by isolation, quarantine, and even once you have vaccine, means reaching the most vulnerable. Because you can tell people their status, but if they don't have the means to quarantine, they don't have the food, they can't take a day off from work, they can't have transportation, then you can't contain the spread among the poor. And we saw that in prisons, we saw that certainly in nursing homes, we saw that in poor communities, and certainly communities of color who are poor. And so we created a cadre that we call the care resource coordinators in the state of Massachusetts, and they would work with the contact tracers. The contact tracers would say, okay, you've been in touch with COVID. These are the things you need to know. You need to get tested. And then these are the things you need to do to quarantine. And if you can't, we will refer you to the community care coordinator. This is a program that was based on advocacy, right? Because we understood that just doing contact tracing without dealing with the materiality of poverty was not going to be equitable. These resource care coordinators speak 23 languages. There are social workers, nurses, psychologists, and they work within communities that they know. Much of this was virtual, but eventually, of course, transitioning to in-person. Just to note that the main type of support people needed was food. And when you think about food insecurity in the richest state in the richest country in the world, imagine what the COVID pandemic has done in cities, in places like Haiti or other cities. So now, of course, we're seeing this terrible inequality with vaccines. So meanwhile, we are working in cities and states around the country, like here we are in Immokalee, Florida, working together with the coalition of Immokalee workers, CIW, to try to get testing into Immokalee. It's our team from Haiti, actually, who went to Immokalee and team from Mexico to set this up. And most of the people who need support speak Haitian Creole, speak Spanish or Guatemalan language. So what's the next step? Well, we need to see this reality that the same forces of inequality are meaning that we have vaccine apartheid. And so given our work now in inequality in the United States, we're working on trying to make sure that those Immokalee workers get vaccinated too. But meantime, we have to say that our countries around the world that have done much better against COVID are not getting the vaccine simply because they're impoverished. And so now working with activists, many of the same activists I've worked with for years on HIV, we're trying to say, how do we break this cycle of pharma being involved in profits only and not equity? So the roles that we play as physicians, I think, are around the knowledge that we have, the social connections we can make with activists, with patients, and around how do we translate that into policy. And so just to say that this work has been ongoing since the beginning of the pandemic, and we've had some successes. One is we were able to get Biden to support the TRIPS waiver, which is to waive patents during the pandemic. We still need to get the language of the law. We still need funding. We need widespread manufacturing. Similarly, we were able to get the Biden administration to commit within the American Rescue Plan for the Public Health Job Corps, which is to pay community workers to do the very things in the United States that we understand are needed. And now we're working with cities and states around the country to access those funds so that they can rebuild their public health infrastructure. So I'll stop there and just say, there are so many ways that we can be involved, giving the knowledge we have. My knowledge is really in infectious disease and global health and public health, and so I've been very helpful. But many of you who are clinicians, you may be on a different piece of that. But it's really about not individual advocacy. It's about advocacy within a social movement and a context. So I'll stop there. Thank you very much.
Dr. Mukherjee, thank you so much for just illustrating both the breadth of the work that you've done, but also how you've done it and how Partners in Health has done it sort of hand in glove with workers' movements and movements of patients and communities of color. I think that's something we're all aspiring to learn how to do better and how to initiate those relationships and build those relationships, especially when response needs to happen quickly, as it has in pandemics. And so with that, I'm excited to transition to our second speaker, Isabel Cruz. Isabel is from the Colorado Consumer Health Initiative and is a passionate advocate dedicated to amplifying the voices of consumers and marginalized communities to promote equity and wellness in Colorado. Isabel's originally from Brooklyn, New York, and received her bachelor's in sociology from Yale with a certificate in human rights. And since then has over 6 years of experience in nonprofits in New York, New Haven, and Denver, with a career dedicated to building power and nurturing leadership across diverse groups to advance social change across the country. In her role at Colorado Consumer Health Initiative, Isabel is bringing people together to advocate for policy solutions to make sure Coloradans can access affordable and affirming healthcare. And in her free time, she explores Colorado on her bicycle with her dog Mariposa and via ultimate frisbee. And so now I'm going to turn it over to her to share her remarks and presentation.
Thanks so much. I am so excited to be a part of this space. I really appreciated Dr. Mukherjee's remarks as well, and hope that mine will complement them well as well. So I am going to share my screen. All right, I think that looks like it's up okay. Let me put it in presentation mode. Right. Let's see. There we go. Awesome. All right. Well, good morning or good afternoon, wherever you are in the country. I'm currently in Colorado, so it's still technically morning here. As Justin did with a lovely introduction, my name is Isabel Cruz. I use she, her, hers, yeah pronouns. I'm the policy manager for the Colorado Consumer Health Initiative. Our mission is, as a statewide advocacy organization, to promote equitable access to affordable and high quality healthcare for Coloradans. And I am really excited to be here to talk to you today, complementing this really incredible sort of global perspective that Dr. Mukherjee was able to bring. At the local and the state level, even though I think that she really brought in a lot of incredible themes around similarities in what working together looks like, what people power really means, and how you cultivate that in an authentic way, and how you can make real change in our healthcare system, which can sometimes feel like a daunting task for me as a consumer advocate, and I'm sure for many of you all as physicians as well. So just as a little bit of a roadmap, I'm just going to talk a little bit about what state and local advocacy looks like. What are some of the players at the table? What does finding your role in those spaces look like? And if you decide to lead an initiative or try to get involved with an initiative, what are some of the best practices, particularly with regard to working with grassroots individuals, particularly grassroots individuals with some of the greatest barriers to accessing healthcare? And then I can talk a little bit about what that's looked like for us with prescription drug reform here in Colorado, and then just a few key takeaways before we dive into a conversation between all of us. Then I'm really excited. So as just an overview, I know we're probably all coming to this table with different levels of experience and understanding with local and state advocacy. So this might be sort of review for some folks, but I think it's really important to talk through sort of what the scope of sort of the players out there, if you're trying to make a change, like Dr. Mukherjee was talking about at the local and the state level. And so that we can really drill on what is the difference between sort of engaging just broadly, which is important, and what's the difference between engaging with grassroots and community organizations. So first, I think decision makers, right? It's kind of, I sort of was torn about separating it from government because, right, a lot of times we view the decision makers as the government based on the kind of intervention we're looking at, right? Like I come from an organization, we work a lot on regulation, we work a lot on state policy. So a lot of the times we're looking to our state regulators, to our legislators as decision makers. But those are not always the same folks. Sometimes you're trying to work in the private sector, right? For workers, or for folks who are, trying to move other decision makers. And so, right, there's these different levels of sort of people who have what we would call institutional power, right? And grass tops organizations, which is where sort of my organization, Colorado Consumer Health Initiative, falls, are sort of starting to get in the middle of those, right? For folks who have sort of this institutional power, have sort of the final say, or have particular roles in sort of the ways that institutions work, and are oftentimes the biggest players in changing those institutions, right? And so grass tops organizations, if you're unfamiliar with the term, are organizations that are, you can think of as like an NGO or a nonprofit, or organizations that have relationships with people with institutional power. Oftentimes it's a more professionalized role, right? Like this is my job, right? Whereas a lot of grassroots organizations, it's more about sort of people on the ground with relationships to community, who oftentimes aren't paid, or it's not as professionalized or seen as quote unquote as expert of a job in a lot of ways, even though that's, I think, part of what all of us here today are trying to complicate. And so for grassroots and community organizations, as I said, right, that's, I think, where I'm gonna dive into sort of the kind of connections and what outreach looks like and what best practices for outreach looks like. But if people have questions sort of on some of the other realms, I'm happy to talk through that in our question and answer portion as well. And also just want to name that individuals, even separate from grassroots and community organizations, is another sort of real topic of how to do outreach, right? Because there's a lot of people who are awesome and have a lot of lived experience in surviving these systems that we're trying to change, living these health disparities that we're all really passionate about changing. And outreach to sort of individual people looks a little bit different. And again, happy to talk about that later if folks are curious. Yeah, I think it's important to just recognize that building coalitions that involve as many of these types of groups as possible, right? If you can get your decision makers on board with your issue and your kind of intervention, right? Or, you know, if you can get state agencies, right, these people with institutionalized power, folks like us at CCHI who, you know, can sort of play both of the sides with regard to some of the policy expertise and the relationships that we have. But I think it's really important that the people closest to the pain are the closest to the power, right? So centering outreach to grassroots and community organizations, I think, is a really, really important part of building a strong coalition, which is what we're talking about here today. So I think I am currently in a grass tops role. I've been sort of in more grassroots spaces throughout my career, and I've learned a lot, both from people from the perspective of, you know, having folks reach out to me or working with folks who are interested in engaging in an issue or interested in a kind of intervention. And also from the place of there are levels of which I have privilege, right? My educational privilege, my wealth privilege, right? And so I'm coming at this from a place of not expertise in some ways, but some learned lessons with regard to how grassroots outreach can look really good and how to avoid some of the pitfalls that have historically happened in reaching out to folks in the community to make change. So I think it's really important to really be grounded in the history of what a lot of grassroots and particularly folks from marginalized communities, as Dr. Mukherjee was saying, you know, communities of color, BIPOC communities, low-income communities, immigrant communities, LGBTQ, right, folks who have lived experience of historical and continued oppression, that there's a lot of reasons for folks to distrust outreach, right? There's a lot of reasons and a lot of history of folks trying to make change or trying to be in coalition or work with other people and not necessarily experiencing the mutuality or the respect that they're deserved in building those relationships. So know that a lot of the times that's a real and important thing to recognize if you're doing outreach with grassroots or community-based organizations. And it's really important to try to mitigate that through these values of earning trust, of sharing power, right? If you, let's say you are trying to make a change at your local hospital, right? Or you see something in your practice and you want to make a bill about it to change what that looks like on the ground, right? And you want to talk to your patients, you want to talk to community groups, you want to talk to people who are most impacted by what you're talking about. It's really important, right, that we as experts, right, you as an expert, as a physician, me as an expert, as somebody who works in policy, we have things to bring to the table, right? But a lot of the times we don't share power with the people who have the biggest stake in the decisions, right? And I think it's really important to value the lived expertise, right? To really acknowledge some of those historical power imbalances. And as much as you can in campaigns, go as early and as often and put as much decision-making power with the communities who are experiencing the health disparity or experiencing the issue that you're talking about to to really ensure that it's an authentic and mutual and a relationship that's going to really push this idea of collective liberation forward. I think maintaining an asset-based mindset is part of that, right? That valuing lived experience is a huge piece of working with communities. And recognizing, right, that there is a lot of pain, right, in experiencing health equity and inequities. There's a lot of pain in experiencing poverty, but there's a lot of skills and a lot of things that people bring to the table that sometimes get discounted in some of the systems that we have built today around how advocacy works, around how change works, around how relationships work. And so I think that really, right, and not all of these things are always possible depending on what kind of a campaign you're working on, right? If you already have an idea and you really want to reach out to people, heck yeah, do it, right? But it's also, it's really important, right? You're more likely to get more people on board or really get people's buy-in if you've had a relationship with them before, or if you show up for their marches, or if you show up for the things that they care about, right? And as Dr. Mukherjee was saying, like maintaining the longevity of the relationship, whether that's through you or through the organization that you're working with or through the group, right? Like, I think that that's a huge piece. And, you know, as she was talking about working towards accessibility is a really big piece of that as well, right? And recognizing the real barriers people have to engaging, right? To showing up, to giving their time, to what they can understand based on the educational opportunities that they've had access to, or the language that they speak, or the, you know, cultural understanding that they have, right? And being honest with those limitations, right? We don't always have the funding to give everybody childcare, to give everybody, you know, translation, right? But being really honest about what inclusion or accessibility looks like is really key to maintaining and building trust with people as you reach out to them. And so I could talk about this for a long time. I'll probably go through the next parts a little bit more quickly and hopefully just leave some more space for questions. But I think it's really important, right? Like, and I've come to this a lot from my sort of positionality as, you know, a queer woman of color, but also somebody with levels of privilege, right? What is my role in all of this, right? As somebody who really believes in the project of social justice, really believes in health equity, right? And really believes in the power of people to come together to improve systems. Where is it my place to lead, right, with the expertise that I have with my organization, and where is it my place to follow, right? And I think that I just want to name the tension that there is, right? I think deferring to community leadership is critical, right? Recognizing the work that's already happening in community is key, but I also think that we can sometimes fall into the pitfall of putting the onus on directly impacted people to fix systems of oppression, when sometimes the lived conditions of their lives make it the hardest, right, for them to carry that fight. So I just want to name that tension, and I don't have any perfect way of navigating it, but it's real. And I think it's important to just carry with you as you figure out where your place is. And so I put a few questions on here about what to consider when finding what your place is, right? And I think the moral of the story is recognizing who has the biggest stake in what you're doing, what are they already doing, what do they care about, what role would be helpful for you in the capacity that you have to play. And if it is decided that you should lead, what does accountability and partnership look like with the people who have the biggest stake in what you're doing? And so sort of on that vein, you know, successful coalitions, I think, have directly impacted people, and those who can speak best to decision makers and combat at the opposition, right? Like, I think I spoke a lot about really bringing the people, again, the people closest to the pain, closest to the power. And I think that there's some really great opportunities for partnership across groups you might not expect, right? And you have to recognize, right, like what are the messages that the people who you need to convince to change something, what are the most effective ways to get to them? Who are those, you know, who can be the deliverers of that, right? Whether it's the faith community, whether it's, you know, people representing a particular group, right? Whether it's doctors, whether it's, you know, I think it's really important to recognize that while still really centering directly impacted people in complement to the messages they're going to get across to decision makers. So I put some key values, happy to talk about them more later, but I think overall, the name of the game is being really authentic, building mutuality, and being really transparent about what the reality of your campaign is, to make sure that all people involved in your coalition are able to fully understand what they're signing up for, how they can engage, providing people who have a lot of time the opportunity to be leaders, providing people who don't have a lot of time the opportunity to engage as well, right? Like through giving them resources, et cetera, and really managing people's expectations, right? I like to say shoot for the moon because sometimes you can land on the moon, right? But be really honest with each other about what your lines in the sand are if you can't even reach the stars, right? If you have to sort of stay closer, if you have to abandon an effort. So I can talk a little bit just quickly about Colorado. We passed some really exciting prescription drug reform in Colorado this past year after years of trying to make substantial efforts in the prescription drug space against really well-funded opposition. And so I think some of the strengths to realize, sort of based on what I talked about before, are that, you know, we, from our efforts, right, how we were able to win, right, like a pared down version of what we had wanted, and I'm happy to talk about that more, but, you know, still a big win, in many ways with help from Doctors for America, which I'll talk about in a second. But I think the real strengths of our coalition was the diversity, right, while also recognizing, right, we had people from physicians, from businesses to faith groups to patient groups to grass tops groups, right? But we really centered equity in how we were thinking about the policy, its impacts, and what our lines in the sand were, right? And provided multiple modalities for engagement to ensure that people across all levels of ability to engage were able to. And I think that there were things to learn, right? Like the Prescription Drug Affordability Board is a grass tops policy. You know, it wasn't like that was what community was asking for and that's what we gave them, right? And I think we can't always do that, but that is really the best practice, right? Is learning the lessons and taking the direction from the people on the ground. And it's really hard to make conversations like that accessible for people, right? And so as people, like with specialized knowledge as doctors, how can you really translate sort of what you're hoping to do, how you hope to change this really complicated healthcare system to people on the ground who experience it, but may not necessarily even understand what's going on because it's so purposefully complicated. And I think, you know, we have a lot of room to grow as an organization for how we engage BIPOC and low-income consumers to really center their voices. Doctors were a huge part of our PDAB. I just want to highlight quickly, you know, there are multiple ways that they help, from testifying. One of our sponsors was a doctor, she's a pediatrician. We had op-eds, we had a great letter to our legislators from doctors. So also to say that there's a number of ways to engage in fights that are happening, as well as thinking about how to lead your own. So I will just close with saying that I want to echo what Dr. Mukherjee was saying, that relationships are really where change happens, and being really intentional about the historical dynamics of relationships between doctors and patients, relationships between advocates and directly impacted communities is really important. But I really believe that people power, change, and healing can happen in relationships, and that can make almost anything possible. So thanks, and I'm excited for the rest of the conversation.
Isabel, thank you so much. That was an incredible presentation with so much gold for all of us to take away, and we'll be able to distribute it hopefully to the attendees at the end, just as a point of reference. But there's just so much to get into, and only a little bit of time. So I wanted to jump off to both of you with a question that one of our attendees sent to me, which is about how to deal with intersectionality of our own identities and of the identities of those that we work with. So a lot of our audience, and I know you, Dr. Mukherjee, probably feel this way as well, we have our roles as physicians and our roles in the communities, but also our identities as, you know, whether it's as a woman or as an immigrant or as a member of a particular, you know, ethnic or racial community, or all of the above. How have you each sort of figured out how to use different aspects of intersectional identities you might hold, or to work with organizations made up of members who have those intersectional identities, when there's more power in one versus another in speaking or in organizing?
Yeah, I'm to jump in. That's a great question, and I know Isabel addressed some of that, and I appreciated that a lot. I think when I was talking about sort of organizing principles, one idea when you're in a coordinated group, right, when you have a strategy, is to do something that Marshall Gans calls power mapping. right? And power mapping is about looking at what you need to get where you want to go. So, for example, in the protest, I showed a picture of the Moderna protest. I wore my white coats and I was a Harvard doctor, right? Because that is the power that the movement needed. They needed Harvard doctors to take the heat. Now, Harvard was not so happy about that, just saying. But, you know, I have been in protests where my role is as a doctor because that's helpful to the movement, right? And so I think to me, it's not really about my identity. It's about what intersections will be helpful to the movement. You know, I'm also the caregiver of an elderly parent. That might be useful in some discussions. I'm also a mother. But it's like what you have, what are the assets you have to bring to bear on a movement? And so my identity, if you will, is whatever asset is most useful to the movement that I'm involved in and passionate about at the time. Isabel, you probably have a much more nuanced answer.
No, I love that. I think that that's real, right? I think it's important as sort of, you know, if there are identities that you can sort of leverage in that way to do so, especially, you know, when you can, you know, be I guess a lot of people use the term ally or the term accomplice. I think that that's super huge in this idea of multi-ethnic, multiracial, multi-socioeconomic status kinds of coalitions. I think just the thing I would add, right, you know, and all of us have different identity, shows up so differently in everyone, right? Like how I understand my identity as I said, you know, like a queer Latina with wealth privilege and with educational privilege, right? Like is different than even somebody who like has that same identity, right? And I think we are in such an age of really sort of like of really black and white conversations around what identity looks like, how you operate in your identity. And there are some ways in which it is black and white, right? I walk into a room, people know I'm a woman of color, right? Like it just happens. And it's not something I can ever leave behind. But at the same time, like I think it's really important to recognize like in yourself, what are the things that you feel give you some pause sometimes, right? And what does that mean about how you want to interact with some other people, right? Like I used to work very closely with low-income parents in the TANF program, and that was a moment where I felt really guilty about my wealth privilege. And I was able to think, actually, like, what is my guilt doing for anybody but me to make me feel like a better person when, like, I am trying to build authentic relationships, amplify the voices of these incredible badass parents, to really see how systems can be made to change to work for them and that their leadership can be highlighted. And so I think that there's an aspect of recognizing power dynamics, recognizing your strengths both as a person, right, your personal identity, what you like to do, as well as your social identity, and then going from there to sort of figure out what you need to be mindful of navigating with people while recognizing that, you know, I really believe in that Audre Lorde quote, right? I'm not free while any woman or person of color is unfree, even if their shackles are not my own, right? And so how can we do that messy, hard work and be accountable for the changes and the issues that come up with that, to really push this idea of health equity, of liberation, of wellness forward.
Amen.
That's great. The next question we have is related to what you've seen or what you anticipate sort of going wrong when building partnerships or trying to sustain partnerships. And so this is kind of a two-part question. The first is sort of in general, in your experience, when you've seen a partnership or a relationship break down, what have you seen be the cause of that breakdown, whether it's a breakdown in trust or logistics or what have you? And then the second part is sort of with doctors specifically, if you have experience with this or just know, what you might anticipate. Are there common pitfalls that doctors should probably avoid in, working with community groups or working with local partners that would be helpful for our participants to hear?
Go ahead, Isabel. Why don't you start?
Okay, thanks. I feel like, you make a lot of mistakes in your life as an organizer, as a policy advocate, or whatever you do, right? And so I think, I think that it is real that sometimes just like logistical things can make a difference, and sort of the role that you play or the kind of relationship that you have can determine how logistics impact the continuity of your relationship, right? So you forgetting, like, sometimes you forget to invite somebody to a meeting who should definitely have been at that meeting, and you have, like wild, we call it session brain, right? When like everything's coming at you from so many ways, right? But if that person doesn't understand that that's not coming from a place of like, I didn't want you at that table, right? Like, or that you didn't deserve to be at that table, particularly if they come from a group that's marginalized or doesn't feel welcome in a frankly very white, very, educated, privileged health policy space, like that, that even though it was a small logistical error, that it's on me also with the relationship, right? And so I think it's just one of those things. If those things are going to happen, it's going to feel really terrible sometimes, and it's important to just really continue to like not let that stop you from trying to build a relationship, from trying to be accountable to people and to community. And it's just going to be hard, I don't know, it's one of those things you have to keep moving through. And I would just say, for the pitfall with doctors, we work with, I learned the term in guild or trade groups versus some of the other more socially minded groups of doctors. And
Yeah.
I think, everybody cares, right? But it comes at it at different angles. And we had like a hearing where we had 100 guild or trade organization doctors in white coats come to the Capitol and, yell about how our bill was going to kill people, and there's value in that, right? You have to protect your patients and your craft as you need to, but I think, and something I've learned too, like really being humble, really putting that expertise in a patient-centered way in your advocacy, I think is a really key thing that I've seen some doctors do really well, and I've seen some doctors really fall on. So I'm really excited to hear what you have to say too, Dr. Mukherjee.
Yeah, I guess the main thing I would say, two things. One, as a doctor, is to shut up, right? Because I think we are trained to be show-offs. And so, oh, I know this, I know that. If you're working with impoverished people, with people who are on the margins, they have no doubt that you know shit. But what they have a big doubt about is whether you're humble. They have a big doubt about whether you can listen or not. So going to a space that you want to be an ally or an accomplice or supporter and just listening and learning is the most important thing for professionals, I think, because everybody knows you're smart, and if you just go in there and try to show how woke you are and how smart you are, it's just like not going to go anywhere. So listening is key. The second mistake, I think, is, so don't try to prove your chops. You prove your chops by not saying anything, by not proving your chops. The second thing, I think, is to not assume that the person who's the best English speaker, the most suave, is going to be the best community leader. And I call that like rookie mistake number one. And especially as a person working in international health, it's always, oh, the person who speaks English. So it's like convenient. But they're not necessarily the person most connected to the community. So how do you avoid that? You just listen, watch, learn from other interactions, because if you start to favor and work preferentially with someone because of their language ability or their ability to do a PowerPoint, you're going to probably select somebody who's not really representative of the people who are the most vulnerable. So those are my two cents.
That's great. Super useful, and made sure in big bold letters to take note of that just for myself. The last question I think we have time for, we may have time for two more, but it sort of jumps off of this and several things that both of you brought up, which is sort of this aspect of storytelling and who's the appropriate storyteller. So often, in a lot of the training that we do and a lot of the advocacy work we try to do, we're trying to combine data and evidence with stories, the story of a patient we've seen, or a story of, an illness or a community we've worked with. But it does sound like there are probably times where it makes sense for us to tell the stories of patients or of others, and for us to find ways to encourage that patient or that community worker or that person affected by illness to tell their own story. And there may be, times when one is more effective than the other, and times when one is just more right morally than the other. How do you figure that out for yourself, and how do you tell people, talk through that in terms of op-ed writing or those sorts of things with folks?
Yeah, I can just start. I tend to avoid telling stories about individual patients just because I don't think it's my story to tell. So I will tell stories about my colleagues because they're my peers. So, for example, in my vaccine advocacy, I've been telling about my colleague here in Haiti, who's one of the only, if not the only, infectious disease doctor in the country and was not vaccinated for 18 months, right? So because she's a colleague, she's a peer. I worry about the power dynamic when we're telling stories of illness. So if I'm going to tell a story about a patient, I often will talk to the patient first, make sure they're okay with that, even if I'm not going to use their name. But also I can tell stories that are composite, and sometimes when I write, it's like a composite story. It's real events, but it's not one person. I personally feel a bit uncomfortable telling patient stories because it really should be their voice. So that's just me, but that's kind of where I try to tell stories about myself and my connection to the movement and why, friends of mine, people I know, not as a patient, but as a colleague, as a friend. And that's sort of my approach. But that doesn't mean it's the right approach, but that's what I do. Oops, sorry.
Yeah, I would just add something small to that, which is, I think that, right, everybody's story is their truth. And as people's stories contribute to your truth, right, in sort of that composite way you were saying, like that, as somebody who is in kind of this profession, even as my job, right, like what I hear, right, like that, those are the times I feel comfortable. I will say though, and sort of like the one thing that I do think, right, like a lot of the times we tap sort of community story, very similar community storytellers to tell the same kinds of stories, right? Because we're like, we want to center people, and that's not centering people in the same way, right? I think I just want to re-highlight something Dr. Mukherjee said, which was, like it's not always the person who's the first to jump at the opportunity that's the best storyteller, and even if it's not the most heart-wrenching, right? Like I think we just fall into these extremes of who should be telling the story when there's a lot of people who would love the opportunity. And just from a perspective of being sort of in the grass tops position, which I think is similar to some ways that, right, some positions operate, which is that like you are seeing themes, those themes matter, and a lot of the times are being invisibilized or not being talked about in the policy space. And so those themes and those things you're seeing patient after patient that you're experiencing do matter, even if it's not like the story of, something that happened to you or your family, right? That I just want to emphasize that those are super important for healthcare advocacy too.
Amazing. Yeah, and I think that's something that I've personally struggled with in the past, and in talking to others and training others. I think it's always the tension, right? Trying to use the power and sort of the respect and the platform imbued in whatever position of privilege that you hold, and in this case we're talking specifically about the white coat, and get a bigger audience and potentially make a bigger impact. But in so doing, you also want to tell stories that are yours to tell, or at least make sure you're telling stories in a way that's respectful, or lifting people up onto that platform with you. And sometimes just how to do that in practice really can be really challenging. So I think with that, we're out of time for this session. And so I just want to give an enormous thank you to both Dr. Mukherjee and Isabel Cruz for joining us now. And again, later this evening at 8 Eastern, 5 Pacific, there will be a second Advocacy Grand Rounds at that time with the same topic and speakers, although obviously not a 100% carbon copy of this session. So if so inspired our attendees, I definitely encourage you to reach out to colleagues, friends, email lists, whatever you have, and encourage people to jump on either Zoom via registration or on Facebook Live at 8 p.m. This event has also been recorded, so it will be available for viewing later on DFA's YouTube channel as well. In the meantime, please take 2 minutes to complete a session survey if you have the chance, and this will also be sent out in the email afterward, and it's been linked in the chat. That way we can learn more from you and about you in terms of what went well and what sessions you might like to see in the future. As I said, it's in the chat now, and we'll follow up via email tomorrow with that link and also with slides and other resources. If you haven't already seen, DFA has a new website, so please take a look, check it out, sign up to be a member, and follow us on social media, Twitter, LinkedIn, and Facebook to stay up to date with all of our future programs and webinars and ways to engage and advocate. And then finally, our next Advocacy Grand Rounds in this series is on Thursday, November 11th, again at 1 p.m. and 8 p.m. And the topic will be related to healthcare for veterans. You'll find additional details in a follow-up email on that as well, including some amazing speakers we have lined up. So with that, just again, a huge thank you, Isabel, Joia, for being here from Colorado, from Haiti, and looking forward to talking to you again this evening. And for all of our attendees, thanks so much, and looking forward to working with you and seeing you soon.